Hi, my name is Siddharth and my topic is ultrasound guided anterior sciatic nerve block. The sciatic nerve arises from the sacral plexus from the roots of L4-S3 and runs through the buttock and down the lower limb. It is the longest and widest single nerve in the body. The sciatic nerve passes from the pelvis through the greater sciatic foramen into the gluteal region. It enters the gluteal region inferior to the piriformis muscle, descends in the muscle plane between the gluteus maximus posteriorly and the obturator internus anteriorly, and passes lateral to the ischial tuberosity to enter the posterior thigh, figure 20. In the posterior thigh, it passes between the adductor magnus and the long head of the biceps femoris. It descends in the groove between the biceps femoris medially and the semitendinosus and semimembranosus laterally. The sciatic nerve descends into the popliteal fossa, where it diverges into the tibial and common peroneal nerves. In this approach, the sciatic nerve is imaged approximately at the level of the lesser trochanter. The anterior approach to the sciatic nerve block can be useful in patients who cannot be positioned in the lateral position due to pain, trauma, the presence of external fixation devices that interfere with positioning, or other issues. The sciatic nerve block results in anesthesia of the posterior aspect of the knee, hamstring muscles, and entire lower limb below the knee, both motor and sensory blockade, with the exception of skin on the medial leg and foot, supplied by the saphenous nerve. The skin of the posterior aspect of the thigh is supplied by the posterior femorocutaneous nerve, which deviates away from the sciatic nerve proximal to the level of the anterior approach, and is therefore not blocked. Usual ultrasound setting is curvilinear probe and general preset, depth 8 to 10 cm, using short bevel 12 cm needle and plane, or out of plane approach with 15-20 ml of local anesthetics. The anterior approach to the sciatic nerve block is performed with the patient in the supine position. The hip is abducted to facilitate transducer and needle placement. When feasible, the hip and knee should be somewhat flexed to facilitate exposure. For nerve stimulation, exposure of the calf and foot are required to observe motor responses. In either case, it is useful to expose the entire thigh to appreciate the distance from the groin to the knee. At this location, a curved transducer placed over the anteromedial aspect of the thigh will reveal the musculature of all three fascial compartments of the thigh, anterior, medial, and posterior. Beneath the sartorius muscle is the femoral artery, and deep and medial to this vessel is the deep artery of the thigh. Both can be identified with color Doppler US for orientation. The femur is seen as a hyperachoic rim with the corresponding shadow beneath the vastus intermedius. Medial to the femur is the adductor magnus muscle, anterior to the hamstring muscles. The sciatic nerve is visualized as a hyperachoic oval structure sandwiched between these two muscles. The nerve is typically visualized at a depth of 6 to 8 cm. The first one is the initial scan by anterior approach and second one is scan after infiltration with local anesthetics covering sciatic nerve. Let's check out real block. The anterior approach is much less clinically applicable than posterior approaches, because the distribution of anesthesia is more limited. A higher level of skill is required. In addition, this technique is not suitable for catheter insertion, because of the deep location and perpendicular angle of needle insertion required to reach the sciatic nerve. Consequently, this block is best reserved for patients who cannot easily be moved to the lateral position needed for the posterior approach. Thank you for your kind attention.